Welcome to the recording and lecture on shock states. Our outcomes include differentiating among the four major types of shock, describing the pathophysiology of sepsis and septic shock, differentiating the systemic inflammatory response syndrome from shock, and finally to determine how primary and secondary responses of multisystem organ dysfunction syndrome result in negative systemic effects. So let's start with some general concepts related to shock. At its core, shock is an imbalance between the oxygen and glucose supply and demand to the tissues and the cells. So when we think that through, then there are some specific and very helpful defining characteristics to think about with shock. Certainly, one of the most important is that there is inadequate perfusion. As a result of the poor perfusion, there is cellular hypoxia. There is decreased energy production, and because of the inadequate perfusion and cellular hypoxia, these cells will shift to an anaerobic metabolism. In most cases of shock, there is, in all cases of shock, there's a decrease in the effective circulating volume, and we'll talk that through as we talk about different types of shock. But we also know that with shock, there's a failure of the compensatory mechanisms, and those mechanisms that should compensate for what's happening are either ineffective or they've become overwhelmed. So what we'll see in shock is a cycle of cell injury. With that cellular injury, as we've talked about so many times, there will be the production as well as the release of inflammatory mediators, and that will lead to changes in the microvasculature, and it may change both the structure as well as the function of the microvascular system. A couple of other things to think about with shock is at its core, and another thing that really happens is that there is an increase in the stress response. As a result, then, we will see increased glycogenolysis, increased gluconeogenesis, and increased lipolysis. Remember that glycogenolysis is the breakdown of glycogen, which is the storage form of carbohydrate, into glucose. And this is going to occur in both the muscle as well as the liver cells. And this is a very important part of our stress response, stimulated by epinephrine and glucagon. Gluconeogenesis is the generation of glucose from non-carbohydrate sources. So it can be from protein or lipids, triglycerides. The whole goal of gluconeogenesis is to maintain the blood glucose level, and most of this is going to occur in the liver. Lipolysis is the breakdown of triglycerides and free fatty acids. There are a lot of different hormones responsible for lipolysis, but epinephrine, norepinephrine, ghrelin, growth hormone, testosterone, cortisol, all of these hormones are involved. And remember, stress response. When we break down lipids, or the triglycerides and the free fatty acids, this yields glycerol. Glycerol is then absorbed by the liver, which then enters that gluconeogenesis pathway in the liver that we previously discussed. So with the glycogenolysis, the gluconeogenesis, and the lipolysis, then, there's going to be a resulting protein breakdown. It's going to result in an acidosis, interstitial edema, again inflammation, and a decrease in immune function. Another important concept and general concept of shock is that there are changes in the microvasculature and metabolism, and both these changes as well as metabolism worsen with the shock cascade. So what are some of the responses to shock? We have cellular, neuroendocrine, cardiovascular, as well as pulmonary and renal responses. Of course, I'm not going to forget those kidneys. So with the cellular responses, we have an impaired nutrient transport, and if we can't get the nutrients there, we're not going to do a very good job of removing the waste products either. With that impaired nutrient transport, that's going to decrease the stores of ATP, which will then shift the cells to an anaerobic metabolism. Along with the anaerobic metabolism and the impaired transport, there will be the production as well as the release of inflammatory mediators. In the neuroendocrine system, we know that there's going to be an attempt to restore blood volume, because remember, we talked about a decrease in the effective circulating volume as being an overall defining characteristic of the shock syndromes. So in an attempt to restore that blood volume, we're going to stimulate the renin-angiotensin-aldosterone system, as well as stimulate the secretion of antidiuretic hormone. In addition, we will see hyperglycemia and peripheral insulin resistance to support that glucose level. In the cardiovascular system, we'll have a failure of the sodium-potassium ATPase pump, which would then lead to decrease in the resting potential and resulting cardiac depression. And this worsens the transport of nutrients, which then would again decrease the levels of ATP and worsen anaerobic metabolism, leading to a buildup of lactate and an acidotic environment. Now, we do try to compensate for that by increasing the cardiac output to increase perfusion. But remember, another characteristic of shock is that the compensatory mechanisms are either ineffective or they are overwhelmed. In the pulmonary system, we tend to see an increase in the pulmonary vascular resistance, as well as hypoxemia. And in the kidneys, we are likely to see acute tubular dysfunction because of the poor perfusion, as well as increased arterial resistance. So when we look then at cellular as well as systemic dysfunction, at the cellular level, we will see intracellular edema. We will see the malfunction of membrane pumps, and we'll see leakage of those intracellular contents into the interstitium. Systemically, we will see a stimulation of the inflammatory cascade, and we will see a lactic acidosis. So let's take a closer look at the individual types of shock. Let's start with hypovolemic shock. And one of the reasons we'll start with hypovolemic is, first off, it is one of the most common types of shock. It is number one on the list with children. I think it's also a good place to start because most of us have seen this either in a profound manner or developing hypovolemic shock. But what's happening with hypovolemic shock is the heart's working okay, but there simply isn't enough volume to supply the periphery. So we've lost the effective circulating volume. As a result of that loss, there is a decrease in the preload. There will be a decrease in the stroke volume. And when you have both a decrease in preload as well as stroke volume, that means the cardiac output is going to fall. When we look at etiologies, number one on the list is acute blood loss or plasma loss. And again, this is the most common. But we'll also see this with any kind of volume deficit. So if you think about GI volume deficit, large insensible losses like from burns. We also will see this with an interstitial fluid sequestration. And this is what we saw when someone had a very low level of serum protein, serum albumin, and the fluid left the vascular space and entered the interstitial space. Again, the focus here being effective circulating volume. Now, we do, of course, try to compensate for this. And so when we try to compensate for this, that's going to stimulate the release of catecholamines. The catecholamines then would increase the heart rate, increase the systemic vascular resistance. Again, stimulation of the renin-angiotensin-aldosterone system and the release of ADH is important as a compensatory mechanism. But as those compensations fail, we will see a decrease in perfusion. Manifestations of hypovolemic shock will relate to the extent of blood or the volume loss that has occurred. So when we think about then those manifestations, those symptoms, if someone has a relatively mild loss, 15 to 30% loss of their volume, you'll see some mild symptoms, a little bit of tachycardia, maybe some cooling of the extremities. those symptoms will become increasingly dramatic and severe as the blood loss or the volume loss approaches 50%. When an individual has a loss of 50% of their blood volume, certainly they're going to have a profound presentation of tachycardia and poor perfusion. A second type of shock is cardiogenic shock. As you can see from I guess I could call it a drawing. Thank you to Dr. Carter Griffin for letting me borrow this. With cardiogenic shock, the heart is failing. So you have myocardial dysfunction. And so as a result of that, you're going to see dysfunction in both systolic and diastolic function. On the systolic side, we will see a decrease in the cardiac output as well as the stroke volume. Because of that decrease, there's going to be both systemic and coronary artery perfusion deficits. And of course, we're going to see hypotension. On the diastolic side, we would expect to see an increase in the left ventricular end diastolic pressure because we're not able to empty the ventricle. We would see pulmonary congestion, so you might see that might manifest as Ralls. And we would certainly see hypoxemia, partly because of the pulmonary congestion. So what happens then is as this ischemia continues to worsen, that will then lead to an even progressive myocardial dysfunction. So when we look at this cardiac dysfunction, we would look for persistent hypotension and hypoperfusion despite adequate volume in the system and or adequate volume and left ventricular filling pressure. So if you think about this in terms of what's happening, remember what's happening in the heart is failing. It isn't because they don't have volume. They've got enough volume, but the heart can't move the volume. The most common etiology to look for in a cardiogenic shock is an ST elevation MI, myocardial infarction. And we know that in STEMI, with myocardial infarction, cardiogenic shock is the leading cause of death in MI. But we'll also see this in cardiomyopathies. We'll see it in heart failure, valvular disease, and in arrhythmias, especially tachyarrhythmias or ventricular arrhythmias. In cardiogenic shock, as that cardiac output continues to decrease, remember we're still thinking effective circulating volume, that will activate the renin-angiotensin-aldosterone system. It will activate the sympathetic nervous system. And so as a result, the kidneys are going to retain fluid. The systemic vascular resistance is going to go up because of angiotensin II, and the heart rate is also going to go up. In cardiogenic shock, as in most shock states, you'll see an activation of both the inflammatory cytokines as well as compensation and as well as complement. So when we try to compensate for this, we end up with an increased workload. The idea being to increase the oxygen, the amount of oxygen we can push out. But what happens with this increased workload is you actually have more consumption of oxygen and the nutrients themselves. As the workload continues to decrease, the heart continues to fail. It continues to have poorer and poorer function. That then would worsen the ischemia in both the cardiac cells as well as the peripheral cells. In obstructive shock, we're looking at an obstruction that impairs ventricular filling, which would then again decrease the cardiac output, leading to tachycardia, tachypnea, and hypotension. Now, McCanson-Huther and several other resources include obstructive shock as a cardiogenic shock. So it really depends on the reference that you might read. So an obstructive shock may be either classified by itself or it may be subsumed under a cardiogenic shock. And the reason some include it in a cardiogenic shock is because of the decreased cardiac output. Obstructive shock can be caused by a tension pneumothorax, a cardiac tamponade, or even a pulmonary embolus. But again, what we'll have to think about in obstructive shock is the heart is pumping, the heart pump itself is okay, but the outflow is obstructed. So then what we want to do is draw a distinction between an obstructive and a cardiogenic shock. In an obstructive shock, there's a physical obstruction that's impairing the ventricular filling and therefore decreasing the cardiac output. So the focus is on that physical obstruction that's impairing the filling of the ventricles, and that decreases the cardiac output. In a cardiogenic, the mechanical or the pumping function of the heart is altered. So the dysfunction is in the heart itself. A fourth type of shock is distributive shock. Distributive shock is characterized pathophysiologically by vasodilation, decreased systemic vascular resistance, and that's different from what we looked at before, and an increase in the capillary membrane permeability. And there are three general types of distributive shock that we usually talk about: anaphylactic, neurogenic or vasogenic, and septic. With a distributive shock, the heart is pumping well, but there is significant peripheral vasodilation. In anaphylactic shock, we're talking about an antigen-antibody response. So this can be caused by any antigen that stimulates a systemic hypersensitivity response. So this could be from an insect bite, it could be a drug allergy, it could be a food allergy, and it's previously preceded by a prior sensitization. Because this is an allergic response, it's IgE mediated, and this is characterized by a very rapid onset. Again, that's consistent with the previous sensitization. What we see in an anaphylaxis is inflammatory and immune mediators that are causing capillary leak. That capillary leak then is going to lead to both interstitial as well as cellular edema. It will lead to the non-vascular smooth muscle contraction, which is why we have the bronchospasm, and the decreased systemic vascular resistance, that makes sense because, again, the vasodilation. In neurogenic or vasogenic shock, we have an imbalance between the parasympathetic and the sympathetic stimulation of the vascular smooth muscle. Now, because of this, then, there is going to be persistent vasodilation in the arterioles. The most common place you'll see this is in a spinal cord injury at or above the T6 or the 6th thoracic vertebrae level, a traumatic brain injury, or even in spinal anesthesia, although that's probably of the three the most common. So when we think about a neurogenic or a vasogenic shock, what's happened here is there has been a decrease in the sympathetic vasomotor input. So that has been decreased. Because of the decrease in the sympathetic input, there is vasodilation. That vasodilation then leads to decreased venous return to the heart. So as a result, what you have is a pattern of arterial vasodilation and venous pooling. With that venous return to the heart decreasing and the arterial vasodilation, you'll see significant hypotension, a decrease in the systemic vascular resistance, and a decrease in the heart rate. These patients can develop a significant bradycardia. The third type of distributive shock is septic shock. Because we see so much of this, let's take a closer look at sepsis and septic shock. Now, this is a piece where I'm going to do some updating from the information in your text. The pathophysiologic mechanisms in McCants and Huther are extremely helpful, and they're still very valid. However, because of some work that was just done at the beginning of this year, the categories and the definitions of sepsis and septic shock have been changed. And I wanted to bring that to your attention. And this is what you should expect if you're asked questions about this on an examination. So in early February 2016, there was a consensus conference convened to look at sepsis and septic shock. And the work on sepsis has been ongoing in the last probably 15 years and has really accelerated in the last 10 years and the last 5 years again. As a result of the consensus conference, there are really only two categories. We're no longer talking about taking SIRS and talking about this within the sepsis continuum as much. So there are two categories, sepsis and septic shock. And I've provided a real quick reference there, but sepsis is defined as life-threatening organ dysfunction caused by dysregulated host responses to infection. So that's an important thing to think about, is the idea of life-threatening organ dysfunction as well as the dysregulation of the host response to the infection. So we know then that although the pathophysiology is not completely understood with sepsis and then also septic shock, we do have some pretty good understandings of that. So we know that sepsis begins with a microorganism being recognized as a pathogen. Because of that recognition as a pathogen, that then sets up injury to the endothelium. That endothelial injury is characterized, as a result of that endothelial injury, leukocytes and macrophages are going to respond. As a result of that response, there will be activation of the cellular as well as humoral response. And we're going to see some capillary leak with this injury as well as the response. And with that activation of the response, we know that we will have cytokines and inflammatory mediators responding. That then leads to an anti-inflammatory response that then starts an additional cascade. That additional cascade has some fairly well-known understandings, and if you focus on this, we're talking a lot about dysregulation and dysfunction. So certainly we're going to have an immune system dysregulation. Initially, we have a heightened inflammatory response, and we're attracting those pro-inflammatory cells. Metabolically, changes are occurring. We know that in sepsis and ongoing into septic shock, this is characterized by changes in the blood glucose level. It's characterized by hyperglycemia, stress response, and that hyperglycemia is associated with increased oxidative stress. In the mitochondria, we're also seeing dysfunction, the negative impact of oxidative stress, decreased protein synthesis, and again, a decrease in the ATP. At the microvascular level, we are seeing a loss of tone, vasodilation. Because of vasodilation, the loss of tone, and that capillary leak syndrome we see with the inflammatory response, the fluid begins to redistribute. And so rather than all of the fluid staying within the vessels or even within the cells, you're going to have capillary leak syndrome. And as we continue to vasodilate and the perfusion continues to decrease, this would be characterized also by hypoxia. At the endothelial level, as I just mentioned, fluid is moving beyond and between the usual cell barriers. And then last but not least, there's an activation of the coagulation system. Again, this is pro-inflammatory, and so we're going to be using those clotting factors. So all of these things are occurring with sepsis and will occur at an even greater level with septic shock. The other major difference that they made at the third consensus conference when they looked at the definitions is they changed the criteria for sepsis. And these are the SOFA criteria, the sequential or sepsis-related organ failure assessment criteria. Now, there are a number of criteria that are included in this assessment. However, there's a shortened version, it's called the QSOFA, that can be used clinically and really helps us focus in. And what's important about this is in the old criteria, we looked at temperatures and we looked at white cell counts as a quick way to look at whether or not someone may be septic. Now we're looking more closely at the effect on organs as well as perfusion. And so as a result, the three quick criteria are a respiratory rate greater or equal to 22, which tells you that someone's trying to either blow off CO2 or trying to bring in more oxygen. Altered mentation, that goes to perfusion, and a systolic blood pressure less than 100 millimeters of mercury. Again, you're looking at perfusion. You know my love of biomarkers, so I had to mention them in relationship to sepsis. With sepsis, there are two biomarkers that have been very helpful. Now, these biomarkers can be used in non-sepsis, but we've used them a lot in sepsis. Lactate can be used in any shock state, but especially with sepsis. With lactate, what we're looking at is with sepsis and with the hypoperfusion of sepsis and the inflammatory changes and the lack of the anaerobic metabolism, we know that lactic acid is either not being cleared, lactic acid is not being cleared, and it's continuing to be produced without adequate clearing. So when you look at a lactate level, you're looking at global tissue hypoxia. What we know when we look at lactate is that an elevated lactate level has been significantly associated with increased organ dysfunction and mortality. As a result, then, if you work with individuals with sepsis and you've been working with lactate levels over the last couple of years, what we're looking at in our goal-directed therapy is to decrease that lactate level by 20% within the first 2 hours. We also know that resolution of an elevated lactate level is associated with a decrease in mortality. So high lactate levels, not good. Low lactate levels, normalizing lactate levels, good things. The second biomarker that we are using, and again, this is newer than using lactate, is procalcitonin. Procalcitonin is a marker that increases prior to the lactate or the lactic acid going up. The procalcitonin has primarily been used in looking at individuals with COPD that have infections and using it to determine whether or not antibiotic therapy has been effective, because procalcitonin has been proven to be especially helpful in looking at bacterial infections. But the value of both lactate and procalcitonin is less on the diagnostic side, but it is extremely helpful to trend because it will tell us whether or not the sepsis is worsening or improving and whether a septic shock is worsening or improving. So let's take a closer look then at septic shock. With the redefinition that we talked about, septic shock is actually being seen as a subset of sepsis. With septic shock, we know that there is a profound underlying circulatory, cellular, and series of metabolic abnormalities, and because of this, there is an increase in mortality. And we know that this is happening, and what we're really looking for is, despite adequate, even though the individual has been given a great deal of volume to resuscitate for a persistent hypotension, and again, this is someone who has sepsis, and despite volume resuscitation, they continue to be hypotensive. This is an individual that has septic shock. We know that this is triggered by toxins from the infecting organism. The most common infecting organisms are gram-negative organisms. Interestingly, if the sepsis is from a gram-positive, like a staph or a strep, and the individual develops a septic shock related to the sepsis, a gram-positive sepsis related shock is associated with a higher mortality than a gram-negative associated septic shock. We also know that in septic shock there is a great deal of organ dysfunction present, especially looking at kidneys and lungs. So a closer look at that pathophysiology one more time. What's happening? Well, you have the inflammatory mediators, and there is significant vasodilation. Because of that vasodilation, there is a decrease in the systemic vascular resistance, and there is a decrease in perfusion. So when you think about someone with septic shock, this is someone who has very warm and dry skin, as opposed to someone with a hypovolemic or a cardiogenic shock that would present as very cold and clammy. In addition to the vasodilation, we have that heightened inflammatory response, and it's also associated with direct toxic inflammatory chemicals that are changing that cell's ability to actually use the oxygen that is being delivered to it. And certainly one of the things we're concerned about in all shocks, but especially with a septic shock, is the potential to progress to a multiple organ dysfunction syndrome. Now, I didn't want to talk about shock states without talking about systemic inflammatory response syndrome. Although previously SIRS, or systemic inflammatory response syndrome, was an integral part of our sepsis and our septic shock definition, as we have continued to learn more and more about the inflammatory response, we've also learned more about SIRS, or the systemic inflammatory response syndrome. And what we've come to understand is it's not just a reaction to infection. Rather, it is a reaction to anything that stimulates the inflammatory response. So as a result, then, we have an inflammatory response that that is a response to let me start over. The inflammatory response is to nonspecific assaults from chemical, traumatic, and infectious stimuli. So it can be a variety of stimuli. Again, the importance of SIRS is that it's a reaction to anything that stimulates the inflammatory response. So if we think about SIRS then, and that it's a response to a nonspecific assault, we know then it's going to start with local cytokines. And the idea of those local cytokines is local repair, to promote local repair and to activate that reticuloendothelial system for repair. The chemokines that are released are supposed to attract the leukocytes that may then cause local destruction or can cause cellular injury if it's not controlled. Those local cytokines can be released to the circulation. When those local cytokines are released to the circulation, it's going to stimulate growth factors as well as continue the recruitment of macrophages and platelets. Now, the inflammatory response syndrome can actually end there if hemostasis is restored. So as a result, then, SIRS is part of our defense mechanism, and it ends if hemostasis is back. However, if hemostasis is not restored, the inflammatory response continues, and as that inflammatory response continues, it becomes destructive rather than protective and restorative. So those inflammatory stimuli continue in the systemic circulation and basically begin to cause widespread activation of the reticular activating system, loss of circulatory integrity, and this can lead in end organ dysfunction. So let's talk at least a little bit about multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome can be the end sequela of ongoing SIRS, any shock state, and sepsis. And we know that the syndrome is a progressive process. So we're looking at 2 or more organ systems that don't function because of severe, generalized, uncompensated inflammatory responses. So there's your key. And there are multiple etiologies. Now with MODS, or multiple organ dysfunction syndrome, there's both a primary as well as a secondary response. In the primary response, the organ dysfunction is directly related to the specific ischemic and the hyperperfusion etiology. So it's somewhat localized. So that decreased perfusion is local to that organ, but can also, as it continues, become generalized. That initial response in that primary response is inflammation, and a stress response that essentially sets it up or primes the body for a more dramatic response. And this is where the multi-hit theory comes in. So that secondary response is actually is a multi-hit theory, and it's a heightened inflammatory response. But this is now happening in organs that are not involved in the original organ injury. So this inflammation is continuing to perpetuate, and it's progressing. So when we look at that, the hallmarks of this second hit, or the secondary heightened inflammatory response, is extensive endothelial damage, and you're going to see the aggregation of neutrophils in organs. Just remember, these are organs that aren't involved in the original injury. The second piece that's important in the secondary response is a heightened stress response. With this heightened stress response, you're going to have an catecholamine release that increases the heart rate, that increases the metabolism, and dramatically increases the consumption of oxygen. Also with that stress response, there's going to be more insulin, cortisol, glucagon, and ADH secretion. Additional activation of complement, kinin, the coagulation cascade, and the fibrinolytic cascades become involved in multisystem organ dysfunction. So the end result of this multiple organ dysfunction is continued vasodilation, continued inflammation, coagulation that occurs in excess of any fibrinolytic normal pathway. So what can happen because of MODS? Certainly there are a number of negative sequelae that you could imagine. One of the things that we see with MODS, multiple organ dysfunction syndrome, is a translocation of bacteria from the GI tract. This is potentially life-threatening. If you remember that we have a lot of normal flora in our GI tract. As that GI tract is poorly perfused, the bacteria that should stay within the GI tract begin to move out of the GI tract into other cells, other organs, into the circulation. That's one of the reasons why we talk about making sure that we maintain the gut mucosal barrier. Hypoperfusion of the gut is a major negative, causative factor of translocation of the bacteria from the GI tract into the periphery. Also, we have a poorly distributed blood flow. So we know that the blood is going to go to priority organs first, but it's poorly distributed, so some organs aren't being well perfused as well. In MODS, because of this heightened stress response and because of the heightened inflammatory response and the perpetuation, there is a hypermetabolic state. There's also myocardial depression, so you have myocardial depressant factors, and so heart function is going to be diminished. And what becomes very interesting is at the cellular level, consumption of oxygen shifts away from demand to shifting to supply. So it will only use what it gets as opposed to using all that it wants. Hope that makes sense. So as we look then at shock, the basic pathophysiology of shock is pretty much the same regardless of etiology. We have a mismatch of oxygen and glucose supply and demand, and it's characterized by inadequate perfusion. Although treatment of shock states occur in high acuity settings, you're going to see patients present with shock syndromes in all care settings. So being able to recognize as well as determine what's going on pathophysiologically is important for all of us, regardless of setting. I hope this has been helpful, and of course, if you have any questions, please let me know. Thank you for your attention.